Hello everyone, and we are going to be covering fixed and removable dental prosthesis today. And for some reason the word prosthesis looks wrong to me, but I guess it's right. Okay. This is chapter 41 in your 5th edition, and if you have the 4th edition, I don't have off the top of my head what it is, but you can email me and I can figure out which chapter it is. But it might say something like oral appliance or something like that instead of fixed and removable dental prosthesis. So sometimes it's just called an oral appliance or removable oral appliance, something like that. These are the objectives. So I put in this silly little video or pictures. You guys might have seen this before, pop up on Facebook or Instagram or something. They'll take various celebrities that are typically, considered very beautiful and then take out all their teeth and they all look, And so most people don't think about the importance of teeth to so many aspects of our lives. People really do take teeth a lot of times for granted. And so teeth obviously allow us to chew and break down food. Also, there's a great deal of structural support that our teeth give us. And when we don't have our teeth, things start to atrophy and we start to lose structure. Things look sunken or shrunken down. There's lots of things that change our face physically. Speech formation, and then of course just overall aesthetics is, people love to have straight white teeth, but that's sort of a very kind of the having the perfect white straight teeth is a little bit overrated because some character to teeth is actually quite attractive, but a lot of times we think of having those perfect braces, white teeth. Dental hygienists must be knowledgeable about how to meet the specialized needs of patients with a prosthesis. So, a lot of times we'll see patients in our chair with full dentures, and we need to be able, or just maybe a full upper denture, but they still have their some lower teeth, or an upper denture and a partial on the bottom or something. But we need to know how to help our patients keep their mouths healthy and their prosthesis healthy and clean as well. So terminology, at present, there's approximately 1 in 5 adults age 65 and over in the U.S. and Canada who are completely edentulous. The rates have been dropping. People are keeping their natural teeth longer, but the figures suggest that dental hygienists are very likely to encounter edentulous patients within a dental hygiene practice setting. So edentulous is derived from the Latin word edentulus. I don't know, edentulus? I have no idea. I hadn't practiced that word before I started this. But it means to not have teeth, without teeth. Prosthesis is a fixed or removable appliance that is designed to functionally or cosmetically replace the natural teeth. And then that 1 in 5 is about 5% of the adult population that are edentulous. Oral cancer and other and corresponding treatment and oral injuries also contribute to tooth loss. That's not here on this list, but the major risk factor for tooth loss is dental caries and periodontal disease that has gone way past what anyone could do to help. The tooth is hopeless. Low socioeconomic status has a big contributing factor for obvious financial and access to care reasons. Inadequate access to professional care and low frequency of routine like maintenance and preventive therapies. And then overall poor oral hygiene, perhaps because of lack of education or understanding or valuing having a healthy mouth. So prior to 35 years, caries is a major factor for tooth loss. And then after 35, periodontal disease plays a bigger role. Issues experienced with tooth loss. So there's psychological and physiological major events that that are major issues once someone has lost their teeth. Human response associated with tooth loss include like the 5 stages of bereavement, behavioral changes, embarrassment, and loss of dignity. And I have been in the practice when someone came in with a lot of periodontal disease and caries, and they had a lot of work that needed to be done. And so the treatment plan that was going to be what the patient decided to go forward with was extract all the teeth and do a full upper and lower denture. And, I experienced hearing the patients just so frustrated afterwards and really grieving, feeling frustration, feeling embarrassed, coming back and saying, I talk funny, it doesn't feel the same to eat, I'm embarrassed to have the dentures come out, but feeling very uncomfortable with the dentures in their mouth. I mean, it's a host of things that they need to get used to, and it's very challenging. And people really don't always consider that. They just think, oh, I'm not going to have to worry about tooth pain or, getting my tooth drilled on or having my teeth scraped by the hygienist. They think of all these things that they don't like, and they don't really think of the consequences of having full dentures, or even a partial can be very uncomfortable and just take a lot of work to get it fitted correctly. So the responses must be considered when providing care for edentulous or partially edentulous, patients. Older adults will resorb bone faster than young people. Resorption of the alveolar ridge diminishes the stability and the retention of a prosthesis, and the bony ridge continues to flatten over time. Generally, bony changes are observed in the mandibular arch, more significantly than the maxillary arch. It's 4 times the resorption. And the resorption, the changes are more obvious in the mandible, and the resorption rate is 4 times. So these are things that we have to be aware of. Hopefully the dentist counsels patients thoroughly before they go through this. But as a hygienist, if your patient's in your chair, they're talking to you about this option, this is information that you want to have at your understanding so that you can share it with them and help better prepare them. Because sometimes the dentist will talk about something, but when they hear it again from the hygienist, it sinks in a little bit more. Other issues experienced with tooth loss is metabolic, bone disease, postmenopausal, osteoporosis, and calcium poor diets. Those things will exacerbate the physiological changes that a patient will experience. So physiologic problems, I think I stated this in the previous, discomfort related to proximity to the mandibular canal. So as your mandible resorbs and it gets thinner and closer to the canal, they may have sensitivity, they may have nervy twinges, paresthesia in the lower lip or chin related to the mental nerve. So as, again, the bone resorbs and the nerve gets closer to the surface, they may feel some numbness or paralysis. Diminishes stability and retention of the prosthesis, so things won't seat as well. The prosthesis may rock. The retention is not as good as things flatten out. And then again, the resorption is 4 times greater in the mandibular arch. Irregular resorption can create numerous sharp spikes. There can be like these bony areas that don't resorb as fast as another area, and so it is like lumpy or sharp and pokey. Difficult to fit when there's exostosis, so we think palatal tori, mandibular tori, large maxillary tuberosity. Those things can be difficult to fit a prosthesis around. Decreased stability and unbalanced occlusion. Temporal mandibular joint disorders can occur once the patient is fully edentulous and things start resorbing. And then patients are just dissatisfied with the appearance all around. So types of prosthesis, there's fixed and there's removable. With fixed, there's bridges, abutments and pontics are part of a bridge, periodontal splints, or a fixed denture to an implant. Removable would be partial dentures that have the clips that hang on to the natural teeth, an obturator, complete set of upper and lower dentures, and then implant dentures that snap in and out. Some implants are fixed and the patient can't get them out, and then others will come in and out. The patient snaps them over the denture. Individuals can have missing teeth replaced by dental implants, so we talked about that in Chapter 31, or by fixed or removable dental prosthesis. This is a major change and needs time for the patient to adapt. Many patients will say, oh, and I kind of already said this, they'll already say that it's no big deal, but then they really don't understand how their natural teeth really are better than a prosthesis any day. This takes just experience in order for them to really understand this. Especially full dentures affects eating, tasting, food sometimes. Sometimes patients will gag once they get these prostheses in there, especially if it's a full denture and it goes toward the soft palate. It can, all of a sudden, they can gag every time. They have to get used to that feeling. And then the partial denture is used to replace some, but not all of the natural teeth. Partial dentures may be fixed or removable. A fixed partial denture is either cemented permanently to the natural teeth, or it's screwed in, luted or screwed into dental implants. And then the abutment, and is commonly called a bridge. If it's like a 3-unit cemented in, we call it a bridge. Or more than 3. It can be more than 3 units. It could be, 4 or 5 units. A lot of times they don't want to make the span of a bridge more than 3 teeth, but I have seen it bigger than that. And then, of course, it cannot be removed by the patient if it's fixed. All right, so some images here of some removable partial dentures. This is the kind of the support over the palate, and then these little hooks hook onto natural teeth. You can see this is a fake tooth there, and then across here the premolar and 2 molars are not real. So this is a removable partial that helps fill in the posterior teeth. And then oftentimes it can look like this. From the outside, from the labial view, you can see they'll add fake gums to wherever the teeth are, just so that it kind of fits in the smile line. But then you can see these metal clasps. Nowadays, a lot of times patients will go for these all plastic partials, and so there is no metal. They're not as rigid, and they are more flexible. And then they can also be like mostly acrylic or mostly plastic with a little bit of the smaller clasps. So it can be different dentists will do different things and talk to the patients about the options, about which one they want. I'm having the hardest time talking today. I don't know, my words, my tongue is like not working in my mouth. Okay. These are pictures of complete dentures and then an overdenture. You can see these little areas where this snaps into the implants. And then components of a fixed prosthesis, we have the abutments, which are on either side of what's called the pontic in the middle, and the abutments will be cemented or screwed into something fixed, and then the pontic just kind of is the bridge or the floating part where there's no natural tooth, no implant. Obturators, if a removable dental prosthesis is designed for a patient who has undergone either oral cancer surgery. It also may need, oral cancer surgery or oral facial clasps. So usually, or trauma, there could be some kind of major trauma as well. But basically it's sealing up an opening of communication between the nasal cavity and the oral cavity. This may have been caused by cancer, or an accident, or a cleft, like we said. And then in such cases, the obturator aids in retaining foods and fluid in the mouth and keeps them from going up into the nasal passage. So this is treated and cleaned just like a full upper denture. The patient has to take it out and scrub it, gently every day. We can clean it in our office, in our designated oral prosthesis ultrasonic. Usually offices should hopefully have one that's designated just for that doesn't get mixed up with the other hand instruments and stuff. And so basically the cleaning instructions for a patient is the same. You want to make sure it fits well, it's not causing trauma or irritation, that they're cleaning it and removing it to let the tissues breathe. Educating the patient. So patients need to be informed about the physical manifestations of bone resorption related to facial appearance, potential speech difficulties, and the effects of tooth replacement on masticatory efficiency, or how well they can chew. If the realistic expectations and goals for care of the prosthesis are outlined early, so if we tell the patient this ahead of time and we make sure that they really understand, then the patient can adapt successfully to his or her artificial dentition. It's the patients that really go in with their eyes open and have been educated well, but sometimes you get that and then it's still afterwards they're like, oh, this is awful, you didn't tell me, So it's not always an easy thing, but it's our part to make the education experience as thorough as possible. Two primary reasons for reduction in their masticatory abilities. So we have education and expectations, eating, speech, and appearance. So with eating, the two major reasons are 1, loss of periodontal support and stability, and 2, loss of periodontal proprioception. So without feedback from regarding like movement and position from the baroreceptors of the periodontal ligaments, so there's no feedback about what's happening because there's no periodontal ligaments because there's no teeth in their mouth. So without that whole system, the ability to chew declines significantly because we get a lot of information, our sensory information in our teeth and around in the ligaments. There's a lot of information that goes to our brain that helps us know how to move our jaw, how much pressure to use, how to grind, which ways to move our teeth and all of that sort of stuff. And it's lost when you have a complete edentulous mouth. So they have to really learn how to chew again with this new device. So biting and chewing forces are decreased significantly, can be nearly 5 times less in people who wear complete dentures. The patients have greater success with a new prosthesis if they are taught to avoid repeated incision using anterior teeth. So it's kind of like learning to chew again from scratch. So not so much little tearing with the anterior, not chewing gum because that's going to just throw them off of how you chew gum differently from how you'd eat food. I don't even know. I think chewing gum wouldn't even remotely be nice to do with dentures. I can't imagine doing that. Or sticky foods, because obviously sticky foods could dislodge the denture or throw it off from the way it is held in the mouth. So patients also need to be instructed to consume foods in smaller pieces, lengthen their chewing time, and chew evenly, distributing food on both the left and the right posterior sides of the mouth. So basically they're not going to have as much ability to use their anterior teeth, and then they can't chew real sticky, chewy stuff. So those are things they're going to have to sort of adjust and do without. So biting into apples, corn on the cob, things like that. But then when they're chewing everything else, small bites and then that grinding in the posterior region. To facilitate speaking with a new dental prosthesis, patients need to be instructed to talk to people as often as possible for practice, as well as read aloud and articulate in front of the mirror regularly. So people that they're comfortable with, their family, they need to have their prosthesis in their mouth and communicate. And then also just if they're having a lot of difficulty, talk out loud when nobody's around, or practice in the mirror. So it's relearning again. Okay, education and expectations continued. So we touched on a little bit of this. I'm kind of jumping around a little bit, but the majority of this is part of what you educate your patients about. The majority of the alveolar ridge is resorbed. Resorption occurs in the first year. So they go in for multiple adjustments within that first year, because there's going to be a lot of remodeling of the soft tissue and the bone in the first year. Adjustments for the first 6 to 12 months. Bone resorbs faster in the mandible. The alveolar ridge continues to change throughout life. Some people, it resorbs very quickly. Other people, they don't have too much resorption. They're more fortunate. So you really know until it happens. New dentures are relined, needed approximately, new denture relines. New dentures or relines, oh my gosh, you guys help me, are needed approximately every 4 to 8 years. I have seen patients keep dentures much longer than 8 years. I've had patients say, I've had my dentures for 20 years. I don't need new dentures. As long as they're functioning, they don't have some kind of trauma or some kind of a lesion or some kind of an infection, and they're happy, it's fine. But oftentimes things will wear out and they'll need to be addressed. Dentures should be permanently marked with a wearer's identification. This is a good idea to have them somewhere in where you can't see, obviously, in the palate or something. Okay, so prosthesis placement induces unfamiliar forces that contribute to the following. So the three major things that we have sort of been talking about this whole time are residual ridge and alveolar bone resorption, oral mucous membrane remodeling. So there is remodeling and changes that happen in the mucosa, and then loss of orofacial muscle tone, like we talked about. Okay, so oral mucosal conditions usually caused by improper oral hygiene care, extended denture wear, and poor fits. So if a lesion is forming, if there's an infection, it's probably one of those three things. The denture is not fitting, they're not removing the denture to let their tissues breathe and slough off the dead cells and everything, or they're just not cleaning it. They're, improper oral hygiene care to their oral mucosa. They're not rubbing it, brushing their tongue or rubbing their mucosa, or they're not, and their denture's dirty. Factors affecting oral mucosa of denture-wearing individuals. So a couple things can be going on. Systemic diseases and conditions. So these conditions here, diabetes, anemia, menopause, malnutrition, these can all be systemic reasons that you can see something happening in the mouth, a lesion or a condition that's happening in the mouth. Poor general health, if they're very dry, if they have xerostomia. Okay, sorry, I had to pause there for a second if the video seems funny. So poor general health, salivary gland dysfunction, so dry mouth can be a significant problem for a number of reasons. A lot of people who have removable prostheses or dentures will be older individuals, and there's a larger population of patients who have dry mouth when they're older for a number of reasons, again, for having multiple medications or having some kind of a systemic condition. So all of these things kind of can compound. Decreased tolerance to stress, impaired healing, emotional strain, and medication. All of these things can affect your body's ability to stay healthy or to heal. And so we can see they can be more susceptible to things like candidiasis and things like that. And then over here we specifically draw out xerostomia, the role of saliva and dentures. It helps adhesive action if it's dry. And the saliva, if it's coating everything nicely, it kind of helps with that suction. If it's real dry, it doesn't. And then, of course, food sticks to everything and it's harder to clean. And then lubrication and cushioning. Your tissue is just more irritated when it's dry, so the denture will just be far more uncomfortable. Dry mouth causes frictional irritation, altered taste perception, cracked lips, fissured tongue, burning mouth. All of these things we may see in patients that have dry mouth. And we will revisit this over and over and over again because many individuals with special needs will end up with dry mouth as a possible side effect because of medications or something systemic in their body. So the next slide, patients with dry mouth, again, a lot of times it's medication, but the exact cause of xerostomia can sometimes be difficult to identify. Most common, though, it can be associated with Sjogren's syndrome. I always say that wrong, Sjogren's. Emotional and anxiety states can dry out your mouth. Negative fluid balance in the body, selective nutritional and hormone deficiencies, AIDS, anemia, polyuric states, drugs and medication, and then radiation, therapeutic radiation to like the salivary glands or somewhere in the head and neck. So those are situations where oftentimes xerostomia is a definite side effect or part of the condition. So classification of lesions, so different types. There's reactive or traumatic lesions. Definition: secondary or acute to, or chronic to an injury. An example could be an ulcer or a sore. This focal or frictional hyperkeratosis, that is caused by a constant rubbing of the denture on the tissue. Denture-induced fibrous hyperplasia, so excess growth. We call it epilis fissuratum. You'll see that usually in the vestibular areas from a denture that's rubbed and tissue has grown. You can read more about the descriptions here. Then there's infectious lesions related to microorganisms, poor oral health. That would be denture stomatitis, angular cheilitis, or chronic candidiasis. And you can read more of that there. And then mixed lesions, papillary hyperplasia, and I'll show you pictures of all of that. So reactive or traumatic lesion, sores in the mouth. It could be like an ulcer, an aphthous ulcer, or something, but you can see it could be underneath the denture. Like this is when they remove the denture, there's a sore underneath. Of course, you have to be very careful that you're not looking at some kind of a cancerous lesion. So that's why these are so important for us to look at, possibly biopsy, not necessarily. The dentist will help obviously decide that and refer out to an oral surgeon if necessary. And this is just sore from if they have a bony protrusion and the denture's rubbing, it could create a sore. And then sometimes you can get like a secondary bacterial infection. You can get a sore and then something else can get in there and cause problems. Epilis fissurata is this sort of, it looks like a flap of, but it's kind of hardened. It's like a flap of extra tissue that starts to grow around like the ridge, usually the upper ridge of the denture. I've seen it the most on the maxilla, but you can see it on the mandible too, up in the kind of vestibular area, on the vestibule. And it's just like this thick kind of flap of tissue that starts to grow. Hyperplasia, so it's excess tissue growth from irritated, the irritation of the rubbing of the denture. Denture stomatitis, you can see that real red, you can see the outline of the denture. Again here, you can see that the denture's just been there too long. It's made an impression of itself. You can see when they remove it, you can see that outline. So they really need to remove it, clean the tissue, let their tissues breathe, clean the denture. Then candidiasis, usually there's like the white and red combination, tissue sloughing, but it can look different ways. Candidas can look different ways in the mouth. And then angular cheilitis is a fungus also in the corners of the mouth, cracking, so they usually will need some kind of a prescription for antifungal. And then the papillary hypoplasia is oftentimes a combination of Candida albicans and then like a low-grade irritation from the denture. So this might need some kind of an antifungal plus maybe some kind of reline or an adjustment of their denture. So I took this out of the text, caring for the removable dental prosthesis. It's kind of a summary. So I thought this was good for you to make sure that you saw this. Things to explain to a patient, kind of a checklist of these are the things you want to make sure that you talk to your patient about when they have dentures, and the things that, the education that you give them, how to care for their mouth and the denture. So it's a good kind of just like little checklist to go through. Daily oral and dental hygiene care. So advise against denture home care, home repair kits, and encourage the patient to come see the dentist. A lot of times they'll think when they have their denture and it feels good, they might not come for years. And if something feels funny, they'll take out their Dremel and like, you know, do it themselves. They'll just like, I can fix it and grind. And it's really important that they come in once a year, even if they have a full set of denture. And a lot of times patients don't understand that or don't realize that that's important. Discourage denture adhesives in order to really stabilize it and retain their prosthesis. If they need like a pea-size amount, like a tiny little bit, that's fine. But if they need to like slather it in there just to get it to stay, they need it to be looked at by the dentist, and they need an evaluation and for it to be possibly redone. They may need a whole new, or it could just need a reline. Encourage self-examination for proper fit, deposits, and abrasions. They should know what's going on in their mouth, look at their denture, look inside their mouth for red spots or areas that are irritated. They need to remove it at night to let their tissue rest, and brush the denture at least rinse after every meal and before bed. So if they can take it out and brush it after every meal, that's the best, but at least rinsing it off, because food gets under there and it just gets nasty. Chlorhexidine gluconate we can recommend for denture stomatitis. I meant to say that earlier. However, it does stain the denture, so that's important for them to know. And then daily, recommended daily use to immerse, oh my word, see, I cannot talk today. To immerse the denture in a cleaner, preferably at night. So rinse off the saliva and the loose debris and any adhesive material. And then a good thing to do is to use very diluted bleach solution or sodium hypochlorite. You can use 1 tablespoon of bleach to about 4 ounces of water, so it will have kind of a pool water smell. They can use detergent too if they want, like a little soapy, that's fine. Or they can use a just a denture tablet also that kills bacteria and stuff is fine. They soak for 5 to 10 minutes. Or if it's safer, if it's a real diluted, they can put it in some kind of a rinse that says that it can be soaked overnight. Rinse after they've immersed it, and then change the solution daily. It's important for them to brush loose debris to keep it clean so that debris doesn't build up. Calculus builds up on dentures and other prostheses just as much as teeth, if not more sometimes. So it's important that they brush them and keep them soaked to reduce the amount of stain and debris. And also we want to talk to them about how to hold it. It's important, and there's lots. If you have the 5th edition, and I can't remember what's now, I've been looking at the 5th, so now I can't remember what's in the 4th edition, but there's lots of good steps. So make sure you read through those in the textbook so that you know. But a couple key things are how they hold it. They want to firmly grasp the denture in the palm of one hand, and then brush with a very soft denture brush. Encourage the use of abrasive denture powders and discourage the use of abrasive powders and pastes. And then to completely rinse off all the debris and then store it in a cup or in a container, even better. It's also a good idea to have instructions all made up and written up for your, especially your elders, your older patients, to just hand it to them and say, here's instructions on how to care for your denture. So cleaning oral mucosa daily is also really important, and a lot of times it's understood. Patients don't think that they need to cleanse their ridge and their mucosa when they have dentures. So rinse the mouth with warm water and a microbial rinse or a saline solution. Take a soft brush or a soft cloth and do long strokes posterior to anterior, cleaning the ridges to help that tissue that's sloughing, and then also to brush the tongue. Then they can stimulate the tissue. If you take their thumb and the index finger and rub it along the ridge, they can stimulate that tissue, applying pressure, and it also helps with blood flow. It's like a massage for their ridge, and it's good for them. So also teach them to fill the sink with a little bit of water and place a towel so that when they take their denture out and they're brushing it, if it slips and falls, it doesn't break in the sink. So just kind of review again here. Annual continued care. We want to see them once a year. Anyways, it doesn't matter if they have a denture or not. Poor care, then they need to have more frequent visits. If they have infections, if things are not fitting well, then they need to come in more often. Soft tissue examination for early identification of cancer and other oral conditions. Cleaning and maintenance of the denture, we want to make sure that they're doing that appropriately. Adjustments, duplication, rebasing, or replacing, we need to see if something needs to be adjusted, so we don't know that if they don't come in for their recall appointment. Evaluation and reinforcement of good oral hygiene, good self-care, both for the denture and for the oral mucosa. All of that is important and why we have them come in for their recall visits. Professional care of full and partial dentures. The goal is to remove all the plaque and calculus and stain without changing the acrylic or the metal surface. If you can very, very carefully pick off or remove calculus and stain, polish it with like your most fine grit, just barely touching it to remove the stain, but you don't want to get there and like just spend a whole bunch of time with your polish with a medium or coarse grit, because you'll make pits, or you could change the shape of the plastic. If you can very lightly use your ultrasonic to just use the side of your ultrasonic to break up the calculus, and then without using the tip, because if you use the tip, you'll penetrate the plastic. So you have to be very, very, very careful when you go to remove calculus and stain. You can do it. I did it all the time, but you just want to make sure that you're not creating these voids and roughening up the surface so that more plaque and more stain and more calculus accumulates on their denture. Special care is needed to prevent abrasions or wear on the acrylic surface to avoid bending or breaking the partials and the wires of retainers. So you just hold it carefully. You don't put a lot of pressure, or else you could bend or break anything that's metal or plastic. And then professional care procedure. You want to update their health history, client personal history. You update their dental history. You ask the patient to explain anything that's going on with their prosthesis, if they have complaints, if something isn't fitting well. We do a thorough EO, IO, and TMJ assessment, visually inspect their oral cavity for the cleanliness, and palpate you want to palpate the ridge and the palate. Anywhere where the denture is resting on the mucosa, you want to make sure you pull out in the vestibule, look under their tongue, and then palpate those areas thoroughly. Assess the structure and form of the alveolar ridge. Assess the stability during normal oral function. You want to put it in and then see if it rocks, have them bite down, all that sort of thing. Indicate changes in occlusion and articulation, and then assess their oral hygiene status. Page 89 of the clinic manual has our procedure for cleaning an appliance for appliance care. And the biggest problem in private practice is cross-contamination. So it's a really, when you go out into private practice and you go into your new office, make sure that they have a small separate ultrasonic cleaner just for appliances, that they're not sticking it in with everything else, because that's just a big bacteria soup. So if they have a separate one that's just dedicated, it's much more hygienic to do it that way. So there you go. That's our fixed prosthesis. See you next time.